Good afternoon, everyone. Thank you very much for introducing me. It's my great honor to be here at LD Update 2025. My name is Pyoeng Gyun Choe from Seoul National University Hospital. Today, I will talk about infection prophylaxis in liver transplantation, focusing on bacteria, virus, and fungi. As you know, infection remains a major challenge after liver transplantation, and my goal today is to share practical strategies to minimize this risk. As a customary, I'd like to begin with my conflict of interest disclosure. I have received the speaker honoria and served in advisory role for several pharmaceutical and biotechnical companies. I have also participated as a principal investigator in industry-sponsored clinical trials. However, I would like to emphasize that none of these financial relationships are not related to the content of my presentation today. As the surgical techniques continue to improve and immunosuppressive therapy has advanced, the outcomes of solid organ transplantation have shown steadily progressed. Looking specifically at liver transplantation, according to the U.S. Organ Procurement and Transplantation Network, the one-year graft survival rate is 92% for living donor recipient and 91% for deceased donor recipient. Solid organ transplantation has been the improvement of outcome after SOT has been driven in large part by the reduction in infection-related mortality. This graph, based on the U.S. Organ Procurement and Transplantation Network data, shows the proportion of deaths within the first year that were caused by infections across different organ types. In liver transplantation, infection-related deaths declined from about 4 per 100 transplants in 2000 to fewer than 2 per 100 transplants in 2028. However, infections are still the leading cause of deaths in liver transplant recipients. In the first year after transplantation, infection account for about 24% of deaths in liver recipient. Even 10 years after transplantation, infections remain an important contributor, responsible for about 8% of deaths in liver recipients. So, despite improvement in surgical techniques and immunosuppression, infections remain one of the most important threats to both short-term and long-term survivors. This is why prophylaxis and infection prevention strategies are so crucial in liver transplantation. So why do transplant recipients remain so vulnerable to infections? It comes down to two major factors. The first is epidemiological exposures. The environment, hospital stay, invasive procedures, and community contacts that all increase the chance of encountering pathogens. The second is the net status of immunosuppressions. Not only the drug we prescribe, but also the cumulative effect of comorbidities, surgical stress, and underlying liver disease. The successful prevention of infection in the solid organ transplant recipient requires an understanding of these factors to develop an individualized preventive strategies. When you consider antimicrobial prophylaxis after transplantation, there are two main strategies. The first is universal prophylaxis, giving an antibiotic agent to all patients at risk for a defined period. This approach is simple and effective, but it carries the disadvantages of drug toxicity and the risk of resistance. The second is preemptive prophylaxis. Here, we use sensitive assay to monitor patients at regular intervals and intervene only when the test becomes positive before infection progresses to invasive disease. This strategy allows for more tailored use of antimicrobial agents, but it requires strong infrastructures and close patient monitoring. Hybrid approaches that include some period of prophylaxis followed by subsequent monitoring are also common, especially in individuals at increased risk of for infection or in those who are unable to comply with frequent monitoring or intolerant of prophylactic agent. Understanding these strategies is essential because the choice of approach often depends on the pathogen in question, as well as the resources and epidemiology pattern of each transplant center. Now, let's move on to pre-transplant prophylaxis. Before liver transplantation, it is essential to identify and treat conditions that may increase the risk of infection after surgery. So pre-transplantation prophylaxis is really about preparing the patient and optimizing their conditions before they undergo transplantation. Before transplantation, it is essential to evaluate patients for hidden infections that may become life-threatening under immunosuppressions. Subclinical infection before transplant may not cause symptoms but can manifest after transplantation. Similarly, a latent infection may reactivate and lead to fulminant disease after transplantation. This is particularly important in patients from endemic regions where the pathogens such as tuberculosis can reactive. Therefore, careful pre-transplantation screening and management of these infections is crucial for patient safety. Before transplantation, we need to systematically screen for infectious disease and update vaccinations. All candidates should be tested for CMV, Epstein-Barr virus, HIV, hepatitis B and C, and syphilis and tuberculosis, as these infections may reactivate or complicate transplantation. For vaccine preventable disease, patients who are seronegative should receive immunization, including varicella, hepatitis B, MMR, hepatitis A, and COVID-19. This pre-transplanted evaluation not only reduces post-transplant infections, but also allow us to optimize patient safety before immunosuppression is initiated. This slide shows the screening algorithm for latent tuberculosis in immunocompromised patients based on the 2024 Korean guidelines. After excluding active tuberculosis with history, physical examination, and chest X-ray, the process started with IGRA, interferon gamma releasing assay. If the test result is positive, a patient is considered to have latent tuberculosis and should receive prophylaxis. If the result is negative, tuberculin skin test is performed. Patients with induration more than 10 millimeter or more are classified as latent tuberculosis, while those with less than 10 millimeter are observed without treatment. The key message of this slide is that latent tuberculosis cannot be ruled out by a single test alone. Both IGRA and tuberculin skin test should be performed, and only when both results are negative can we reasonably exclude latent tuberculosis. This slide summarizes who should be considered for latent TB treatment among solid organ transplant recipients. First, any patient with confirmed latent tuberculosis, either by a positive IGRA assay or tuberculin skin test greater than 10 millimeter, should receive prophylaxis. Second, patient with a healed TB lesion on chest X-ray, even without prior treatment, should be treated for latent TB, after, of course, excluding active disease. Third, patient with recent exposure to active tuberculosis should also be considered. In these cases, even if the initial test is negative, we start treatment for 2 months and then repeat the latent TB test 8 weeks after exposure to decide whether the treatment to continue or not. Next, I will move on the peri-transplantation prophylaxis. This phase is critical because patients are highly vulnerable during and immediately after surgery. We will focus on strategies such as perioperative antimicrobial prophylaxis and consideration for antifungal prophylaxis in high-risk setting. These measures play a key role in reducing early post-transplant morbidity and mortality. Perioperative antibacterial prophylaxis is recommended for all organ transplant, including liver transplantation. This slide shows the standard guideline table. The choice of agent may vary depending on the procedure and the local epidemiology. An important consideration is pre-transplant colonization with multidrug-resistant organisms such as CRE or MRSA or VRE. These patients are at higher risk of post-peri-transplant and recurrent infections. Some studies have suggested that MDRO decolonization strategies can be effective in reducing infection. And some experts recommend that in patients colonized with MDRO, such as CRE, the choice of perioperative prophylaxis should include an agent active against colonizing MDRO organisms. However, there is still no consensus on how to manage patients with resistant gram-negative bacteria around the time of transplantation. Finally, we must keep in mind that the routine use of broad-spectrum antibiotics increases the risk of C. difficile colitis and resistant fungal infections. Antifungal prophylaxis should be targeted, not universal. Because of drug interaction, toxicities, and the risk of resistance, prophylaxis should be reserved for patients at higher risk of invasive fungal infections. In liver transplant recipients, risk factors including renal replacement therapy, bile leak or anastomotic strictures, large blood transfusion requirement, reoperation or retransplantation, and prolonged use of broad-spectrum antibiotics. So the key point is that antifungal prophylaxis is indicated only in patients with these risk factors, not in every transplant recipient. Finally, I will cover post-transplant prophylaxis. This stage is particularly important because patients remain at high risk for viral, bacterial, and opportunistic fungal infections for months to years after transplantation. This figure illustrates how the immune system is impaired after organ transplantation. Immediately after surgery, the anatomical barrier is disrupted, and with intensive immunosuppressive therapy, cell-mediated immunity falls to its lowest point around 2 to 3 months. This explains why the risk and the type of infection vary according to time after transplantation. In the first months, infections are mainly related to surgery and hospitalization, such as bacterial infection, catheter and wound infection, and early donor or recipient-derived infections. Between 1 to 6 months, when immune suppression is greatest, we see more opportunity infections. These include CMV, pneumocystis, fungal infections, BK virus, and in endemic areas, tuberculosis. After 6 months, the risk depends largely on the intensity of ongoing immunosuppression. Community-acquired infections become more common, but late opportunity infections like CMV colitis, hepatitis viruses, and PTLD can also appear. So the key point is that the timing of infection is predictable, and this predictable pattern provides the rationale for our prophylaxis strategies. Pneumocystis jirovecii is a ubiquitous organism and a well-known cause of pneumonia in immunocompromised hosts. Before prophylaxis was introduced, the incidence of pneumocystis pneumonia was as high as 10 to 15% in transplant recipients. With the introduction of trimethoprim sulfamethoxazole prophylaxis, this infection has been almost completely eliminated as a major cause of morbidity in solid organ transplantations. An additional benefit is that trimethoprim sulfamethoxazole also provides some protection against toxoplasmosis, listeria, and nocardia. So this is really one of the success stories of prophylaxis in organ transplantations. Cytomegalovirus remains one of the most important viral infections after liver transplantation. All donors and recipients should be screened for CMV zero status before transplantation. For the highest risk group, which is donor positive and recipient negative, universal antiviral prophylaxis is recommended. For the intermediate risk group, such as CMV zero positive recipient, a preemptive strategy is often preferred. And in special situations, for example, when patients receive lymphocyte depleting antibodies as induction therapy or for treatment of acute rejection, prophylaxis is generally recommended over preemptive strategies. So, CMV prophylaxis is a risk-stratified approach that is central to post-transplantation infection prevention. This table compares the universal antiviral prophylaxis with preemptive strategies. Prophylaxis is easier to coordinate and provide strong protection, but comes with higher drug costs, greater toxicity, and risk of delayed onset CMV after prophylaxis is stopped. On the other hand, preemptive strategy reduces drug exposure and toxicity, but requires frequent monitoring, higher laboratory costs, and careful coordination. Both strategies can lead to resistance and indirect benefit of prophylaxis, such as reducing other opportunity infection, such as herpes simplex virus infection, have been more clearly demonstrated. So, in practice, the choice between prophylaxis and preemptive strategy depends on the patient risk group, the center's resources, and local epidemiology pattern. There is no single best strategy for all patients. Epstein-Barr virus is an important concern in transplant recipient because of its association with post-transplant lymphoproliferative disorder, PTLD. Unlike CMV, we do not have a specific antiviral therapy for EB virus. Because of this, an optimal preventive strategy has not been established. When we can do is to minimize immunosuppression when possible, as lower level of immunosuppression seem to reduce the risk. Routine monitoring of EB virus DNA is recommended for high-risk patients, particularly EB virus donor-positive recipient negative transplantation, and all pediatric recipients. The goal is early detection of viral replications so that we can intervene before PTLD develops. Next, let's look at herpes simplex virus and varicella zoster viruses. For patients who are not already receiving CMV prophylaxis, it is important to provide prophylaxis against herpes simplex virus and varicella zoster virus, particularly during the first 3 to 6 months after transplantation, as well as during the period of intensified immunosuppression for treatment of rejection. In addition, herpes zoster vaccination should be given before transplantation whenever possible. An adjuvant subunit vaccine, Shingrix, is now available, and it is safe and effective for use in transplant recipient. Let me conclude with a summary. Infection prevention in liver transplant recipient requires a stepwise approach. Pre-transplant screening and treatment of latent or active infection along with vaccination are essential. During transplantation, standard perioperative antibiotics and targeted antifungal prophylaxis are recommended. Post-transplant, we apply pathogen-specific strategy. Trimethoprim sulfamethoxazole for pneumocystis pneumonia, universal or preemptive therapy for CMV depending on donor and recipient serostatus, and tailored prevention for other viral infections such as HIV, HCV, herpes simplex virus, varicella zoster virus, and influenza. The key message is that infection prophylaxis in liver transplantation must always be time-dependent, risk-adapted, and multidisciplinary. Thank you very much for listening.